Professor Martin Marshall from the Royal College of General Practitioners is the chair, and he is going to address you now. Martin Marshall.
Alistair, thank you very much indeed. So I want to take you back in time to the pre-COVID era, if you remember it. It was a long time ago, and describe what general practice looked like, and then describe how general practice changed during the COVID crisis, and then describe what general practice might look like in the future. So prior to the COVID crisis, general practice was under enormous pressure. Demand exceeded supply, and most GPs responded by working harder. We were also very wedded to the long-established model of largely face-to-face 10-minute appointments, which, whilst we had long been computerized in terms of our records, was quite technology light. Then the COVID crisis hit, and general practice transformed itself in an incredibly short period of time. A relatively small portion of practices used triage prior to the crisis. 100% of practices used triage before. Triage, which helps patients, signpost patients to access the most appropriate services for their need. Prior to the COVID crisis, 80% of consultations were carried out face-to-face. During the crisis now, about 80% are carried out remotely, mostly using a remarkable technology called the telephone, which has been around for 150 years, but sometimes using video consultations as well. We're starting to remotely monitor patients, particularly those in care homes, blood pressure, pulses, oximetry, and such like. Increasingly, we're using technology to improve the interface between general practice and hospital services with joint Zoom-based consultations between GPs, specialists, and patients. We're increasingly seeing general practice getting engaged with a public health model, looking not just at the health of individuals, but looking at the health of communities as well. We're seeing general practitioners engaging dramatically with research agendas, contributing to research studies, improving access to data. And finally, and perhaps highly refreshingly, we've seen a dramatic reduction, as Camilla mentioned, in administrative responsibilities, a reduction in 28% in administrative work, in particular around contract compliance. So dramatic changes in a short period of time. What will the future look like? Well, our role as a Royal College is, first of all, to identify which of the changes that we've seen are good ones for patients and good ones for the NHS that we want to persist with, we want to embed in the system, but also to identify the changes which were appropriate during a crisis, but we need to push back on and reverse as we move forward. Now, identifying the good and the bad is not as straightforward as it might seem. So if you look at triage, for example, surely triage is a good thing, signposting patients, perhaps, but it does really feel like a production line to many patients, and often it acts as a barrier to those with greatest need who are least able to communicate what they want. Remote consultations must be a good thing, surely, and yet face-to-face consultations provide the essence of what general practice is about: trusting relationships, the use of touch, the ability to understand non-verbal communications. Responsibility for populations also must be a good thing, you would have thought, but sometimes there's a tension between our advocacy of individual need and the needs of wider populations. So I'm not going to pretend right now that I know what general practice will look like in the future. What I do know is the future needs to be driven by a much more open conversation between the public, people who use services, and clinicians who provide services. And that's really what we need to focus on over the next few months in order to embed the positive changes that COVID has led to.
Brilliant. Martin, thank you very much indeed. And right at the very top there, using technology more and feeding back through with research papers from GPs to the collective.